Dr. Key and Mr. Yusari as well. So my name is Mong Hui Yen, and I will continue the presentation with the topic lower GI bleed, lower gastrointestinal bleeding, and my supervisor is Dr. Key. So lower GI bleed is actually defined as the bleeding originated from the duodenal junctions, or more precisely, is originated from the ligament of Treves. So the ligament is actually located at the fork portion of the duodenum, and it connects the fork portions of the duodenum to the diaphragm near the splenic flexure of the colon. So majority of the lower GI bleed is actually self-limiting. Only 10 to 20% of the patient will come presented with a massive lower GI bleedings. And the cases of lower GI bleed, the incidence actually increases with age, with the most common cause of significant bleeding is actually diverticular disease. So for the lower GI bleeding, we can classify them into few categories. The first one is anatomic, vascular, neoplasm, or inflammatory. So under anatomic, we have the diverticulosis or diverticular disease, which is the outpouching of the lining of the GI tracts. And then we have vascular, which is angiodysplasia, ischemic, hemorrhoid. All these I will explain it in more detail later. And under neoplasm, we have polyp or carcinoma. And under inflammatory, if it's infectious, we have salmonella or shigella infections. If it's non-infectious, then we have Crohn's disease or ulcerative colitis. So the presentation of lower GI bleed actually can classify according to the extent of the bleeding as well, which are the moderate bleeding, the massive bleeding, or clot bleeding. So if patient is presented with the massive bleeding, it's normally the patient which more than 65 years old for age, with multiple comorbidity or medical problems. So they were presented as a hematochezia, which is the passage of fresh blood through the anus. And because of the massive bleeding, so patient will have being hemodynamically unstable. The sign is like, example is like hypotension, tachycardia, or tachypnea. This I will explain it later as well. And then if you take the blood investigation, you will note that the hemoglobin level is low because of the massive blood loss. And the most commonly caused will be the diverticulosis or angiodysplasia. And in view of the massive bleeding, if there is no proper resuscitations take place at time, the mortality rate is actually quite high as 21%. So for the moderate bleeding, the patient can be presented with any age, and the presentation is same. Patient will present as hematochezia, but compared to the massive bleeding, patient will comparatively more stable, but we have to monitor the vital sign as well. The causes can be a long list, including the benign anorectal, which is the hemorrhoid, can be inflammatory, or can be neoplasms like the carcinoma. For occult bleeding, the patient can also present with any age, and instead of coming with the complaints of hematochezia or the bright red blood per rectum, patient normally will present with anemic symptoms like lethargic, poor appetite, or others. Then when you take a blood investigation, you will note that patient is having low HB, and then from the iron profile, you will see there's a iron deficiency anemia. And when we take the FEP, we will note that patient is having a microcytic hyperchronic anemia. This is due to the anemia of bleeding disease. The causes of occult bleeding can same as moderate bleeding, can be long list, can be congenital, inflammatory, or neoplastic disease. So this is another slide of presentation of lower GI bleed. So the patient typical, you are presented as hematochezia, is a passage of fresh blood through the anus, usually in or with the stool. So from the history base, we have to ask the patient whether the blood is mixed with the stool or is separate, like is it campur dengan najis or tak campur. And then after that, we also have to ask whether the blood is after the defecation, because if in hemorrhoid, the presentation is actually the splashing of blood after defecations. And in occult lower GI bleed, as I mentioned just now, patient were presented with the anemic symptoms like dizziness, tired, loss of appetite, pallor, abdominal pain, chest pain, or even SOB if there is a severe anemia. And after that, if patient is presented with a massive bleeding, we have to worry about the hemorrhagic shock, because patient were presented with tachypnea, tachycardia, hypotension, weak pulse volume, and cold and clammy skin, and even low urine output because of the splenic vasoconstriction factors. Okay, so before going to the investigations or endoscopy, we have to have a few differential diagnoses in our mind after knowing the history from the patient. So if the bleeding is presented together with pain, we have to suspect there may be a fissure. And if there is associated with a mass valve, it can be a prolapse hemorrhoid, which we can be visible from if patient is in the lithotomy positions, or there is maybe a carcinoma of anal canal or rectal carcinoma when we do a DRE. And there's maybe a prolapse rectum or prolapse rectal polyp as well. However, if patient presented with a rectal bleeding without the pain, then this we have to get the history well from the patient. If the blood is mixed with the stool, the darah is campur dengan najis, that means that the bleeding is actually at the higher part of the lower GI, so it can be a colon carcinoma. But if there's a blood streak on the stool, it's actually the bleeding is at the more lower part of the lower GI, which it might be a rectal carcinoma. And if there's a splashing of blood onto the toilet bowl after patient passing stool, then it might be a hemorrhoid. And if there's associated with the mucus, then we have the suspects of the inflammation, is the colitis. And if there's only blood alone, even without the defecations, the patient might be presenting with, might be having a diverticular disease. So these are all the differential diagnoses. So when patient come in with the lower GI bleed, the approach we have to do, the first one, we have to see about the patient general condition, whether the GCS level is full, whether the patient is ballot or not, and how about the hydration status. Then after that, we have to take the vital sign of the patient to make sure that he or she is not in the shock status. Because if patient is in the tachycardia, tachypnea, or sorry? Okay, I continue. And then after that, we have to do the abdominal examination to rule out the other causes. The patient might be presented with a mass at the abdomen or any tenderness or generalized abdominal pain suggestive of peritonitis. And if there's a palpable lymph node, if it's a tender, maybe suggestive of infections. If it's non-tender, then it might be a carcinoma, which already metastasis. Then after that, DRE is very important because from the DRE we can know that whether the patient is having a brownish stool or hematochezia. Then, for example, the rectal CA can be palpable when we doing the DRE. And then if there is a tenderness when we do a DRE, patient might be having a fissure or a fistula which is infected. Lastly, we can also proceed with the proctoscopy to see if there any dilated vessel or visible bleeding. Okay, so after that, we can proceed with the laboratory investigation. So from the full blood count, we have to know, the first thing we have to see is about the HB, because patient is presented with the bleeding. So we have to know that it's either a massive bleeding or moderate bleeding, because sometimes from the history wise, it's not adequate. Or maybe patient is presented with clot bleeding, which he or she doesn't notice as well. So from the hemoglobin level, we can know that whether patient is having much loss of blood. And then after that, we can see from the white blood cell to know whether patient is having an infectious or not. Then from the BUS or RP renal profile, you can see because if the urea is high, it's actually it's known as the uremia bleeding. Is a well-recognized complication in patient with renal failure. So when there's a uremia-induced bladder dysfunctions, they might be causing the GI bleed as well. And then our LFT is more like a standard investigation to see the issues. And then after that, we have to take over the coagulation profile as well to know whether there's a coagulopathy issues. And if patient is in a shock status, then we have to get the ABG and PBG or BVG. And if the hemoglobin come back low or patient is in a massive bleeding, then we have to stand by with the GXM or GSH, so we can resuscitate the patient in time. And sometimes we can stand the stool for FEME, for culture sensitivity, or even the overseas or rotavirus if there is to rule out other causes. So after send all the blood investigation, we can proceed to the endoscopy. So the standard endoscopy for the lower GI bleed is colonoscopy. It's actually a diagnostic modality. So and then if there's if from the colonoscopy, after we have done the colonoscopy and we can't find the source of bleeding, then we can proceed with OGDS. Because if there is a massive bleeding from the upper GI tract, sometimes it will be presented as a hematochezia instead of melena because of the massive blood. Okay, so the colonoscopy is actually a diagnostic modality which you can help in visualizing from the rectum to the last 10 to 15 cm of the terminal ileum. It can be a diagnostic use, it can be a therapeutic use as well. So from the diagnostic, we can see the imaging, can find out the cause, whether there is an ulcer, whether there is a growth or mass, to find out the source of the bleeding. Then if there is a mass or there's a polyp, we can do the biopsy of the lesion in the same setting. And for the therapeutic use is if there's a source of bleeding and it's still active bleeding, we can use the colonoscopy to do a electrocauterization to stop the bleeding. Or there is a polyp, then we can straight away remove the polyp by doing the polypectomy. So just a simple slide about the management. So if patient came in with the massive bleeding, as I mentioned just now, so we have to resuscitate the patient in the short time. So set up the 2 large radula, then make sure the patient airway is flattened, put out the SpO2, make sure and then give the oxygen support as appropriate. And then after that, see the circulation. If patient is low BP, tachypnea, tachycardia, then we have to resuscitate the patient with IV fluid. If it's not enough, then we have to resuscitate with the blood product, packed cell. And then after that, if the patient have been stabilized, then we can proceed with the imaging or endoscopic investigations. Okay, so as I said, the colonoscopy just now. And once we are able to localize the source of bleeding or the locations of bleeding, we can coagulate the bleeding site by administer the vasoconstrictor or any sclerosing agents. And if colonoscopy is unsuccessful to locate the bleeding, we may proceed to the angiography. Okay, so now I will be talking about a few causes of lower GI bleed. The first one is diverticular disease, which is also the most common cause of lower GI bleed. So the incidence increases with aging. It is the mucosa outpoaching found in the lining of digestive tract. It's due to the increase of the high intra-abdominal pressure. So the most common cause is because of the less dietary fiber. When a patient having a less dietary fiber, it will cause the increased duration of transit time and then followed by the increased amount of intra-abdominal pressure. And the most commonly, the diverticular disease is normally located over the sigmoid and descending colon. Okay, so this the picture here show how the diverticular disease show as in the in the colonoscopy. So patient may present in one of the following manner. So as I mentioned just now, it mostly located over the sigmoid and descending colon. So patient will present with the chronic left-sided abdominal pain, and there is also change in the bowel habit. And if there is perforations over the diverticular disease, patient may presented with acute abdominal symptoms of peritonitis. And then the patient will also present with rectal bleeding, which is acute, massive, and have fresh blood. So actually, luckily for diverticular disease, more than 75% of the bleeding stops spontaneously. So the first line of the management is actually giving the patient advise patient for high fiber dietary, and maybe we can give a patient the stool softener like the lactulose. And only if patient complicated with diverticulitis, only we will start an antibiotic. If patient complicated with perforation, then only we will proceed with operations. Then the second cause here is angiodysplasia, is degenerative lesions of previously healthy blood vessel, and is more commonly occur in the cecum and also proximal ascending colons. It is the most common vascular abnormality of the GI tract. Is followed by the diverticular disease. Is the second leading cause of lower GI bleed in patient older than 60 years old. So the patient will come presented with painless hematochezia, and the bleeding is actually low grade. and 90% of the angiodysplasia spontaneously resolve. Okay, so the third one is anorectal disease, which is the hemorrhoid. So hemorrhoid is mostly caused by, in view of the increase in intra-abdominal pressure. So if a patient having a chronic constipations, is straining hard every time when he went to deficit, so it will increase the intra-abdominal pressure, subsequently leading to hemorrhoid. And other causes of high abdominal pressures are, example like obesity and also pregnancy. So hemorrhoid are the cushions of submucosal tissue which containing venule, arterial, smooth muscle fiber, and also elastic connective tissue. So when the patient are in a lithotomy position, we can visualize the hemorrhoid. There's a 3 anal cushions. It's over the 3 o'clock, 7 o'clock, and 11 o'clock position in the anal canal. So the treatments of the hemorrhoid is actually based on the degrees of the internal hemorrhoid, and the degrees are differentiating depends on the degree of the prolapse. So if the first degree of internal hemorrhoid, the hemorrhoid actually doesn't prolapse. It presented with a painless bleeding. So the treatment, we can just advise patient for dietary fibers and give stool softener, lactulose, and patient can do a sit bath. And if there's a bleeding recurrence, or still have active bleeding, then we can proceed with a rubber band ligation or sclerotherapy. Second degree of internal hemorrhoid is actually the prolapse through the anus during straining, and it can reduce spontaneously without manual reduction. The hemorrhoid can reduce it. So the treatment is also same as the first degree. While the third degree of internal hemorrhoids means that the hemorrhoid prolapse through anus and it requiring manual reductions by using manual reductions. So the operation, the treatments can include rubber band ligation, sclerotherapy, or we can proceed with the operation, which is the hemorrhoidectomy. While fourth degree of internal hemorrhoid, the hemorrhoid cannot be reducing anymore. So it can complicated with thrombus. So if this will presented with a very painful hemorrhoid, and patient have to proceed with operative hemorrhoidectomy. Okay, so
there is a few other things modality that we can offer to the patient, especially second degree and third degree. Other than fibro bending, rubber band ligation, and then hemorrhoidectomy, few other things. What other thing that you know of? Takkan ni je. Come on. Second degree. Prolapse, but reduce spontaneously. And then patient bleeding. Then if let's say patient bleeding, and then after that you band patient already, and subsequently still recur again, takkan open hemorrhoidectomy straight. So what other thing that you know of? Where you come across?
Electrocoagulation.
Oh. So we got other, then that is ada ligation of the what? Ligation of the hemorrhoidal artery. One, meaning that we do ultrasound guided, then we ligate the hemorrhoidal artery. Other than that, a bit more simple, we can do laser. Okay, laser hemodopexy. And then one kita ada satu lagi adalah for third degree, ideally for stapler hemorrhoidopexy also you can use. Okay, so mainly these two, ligation, laser, as well as stapler, we give for second and third degree. Right? Okay, continue.
Thank you, Mr. Okay, then the causes of lower GI include anal fissure. So if patient having an anal fissure is a painful bleeding per anus, because there is a tear at the mucosa lining the anus, and when we're usually presenting with the associated infection, because there's a tear at the mucosa, and when patient passing the feces, it will contact with the with our stool, so it will normally associated with infections. So, this one anal fissure can be treated by using an antibiotic, analgesia for the pain, then stool softener as well, also put on the local dry dressing. And then other cause are of lower GI.
Anesthesia, other than that, what is that? Infection is got chronic, how do you know it's acute anal fissure or chronic anal fissure? How do you know?
If chronic fissure patient will have the skin tag.
Sentinel tag,
The tag,
okay.
yes.
Kalau acute?
Just a tear at the mucosa.
Yes, just a tear, like you can see a fresh tear like that. So treatment? Takkan antibiotik. Siapa cakap kat you pakai antibiotik ni? I never heard of that before. Antibiotik okay, analgesia means you want to give a lignocaine gel. Other than that, local dry dressing. Never had that. Apa yang kita buat? Normally in an alus tahu, what do we do? There ada medical treatment dan dia ada surgical treatment. Medical treatment normally we give a pernah dengar tak? Diazem cream, GTM cream. Okay, these two will relax the internal muscle. When it's relax the internal sphincter muscle, it can promote more healing and prevent from the spasm. Another one what we do, if let's say it fail this, then we do Botox injection. Also meant for relax of the internal sphincter muscle. Lastly, so everything is all filled with medical treatment, then we do lateral sphincterotomy. Okay, meaning that you cut part of the internal sphincter muscle. Okay. Okay, proceed.
Okay. So now I'm talking about the fistula in anal. So fistula in anal is a chronic inflammation progressing into the formation of anal fistula. So you were presenting with a patient who complaining there's a watery or there's a pus discharge from the opening of the fistula, and the pain is episodic when the patient will feel pain when the fistula is filled with pus. And when there's a pus discharge from the opening of fistula, it will cause the pruritus as well. So normally the external opening can be easily visible around the anus, while the internal opening maybe can be felt when doing the DIE, which are two of third are posterior, and the first and one third are over the anterior side. So the proctoscopy is essential to visualize the whole fistula and including the internal opening. And the surgical treatment for the fistula in anal is the fistulectomy. So now next one is the inflammatory bowel disease. So under inflammatory bowel disease, we have Crohn's disease or ulcerative colitis. So you can see from the picture there, if there's a Crohn's disease, the lesion is actually discontinuous, which we normally known as a skip lesion. Okay, so mouth to anus will potentially all affected, while for the ulcerative colitis, you can see the lesion is continuous from the rectum and is normally affect only the colon. Okay, so the ulcerative colitis is a lower abdominal cramp which relieve with bowel movement, and patient are presented with bloody diarrhea. Normally it won't feel any abdominal mass. Okay, and for the Crohn's disease is a constant pain often in right lower quadrant which not relieved with bowel movement, and sometimes at the right lower quadrant will feel less, and patient will presented with diarrhea. So for the ulcerative colitis is mucosa disease, while for the Crohn's disease is a transmural disease, which the fistula, abscess, and stricture are all common. So from the endoscopy, you can see here for endoscopy, if it's a Crohn's disease, then you will presented with, like I said just now, the fistula, abscess, and stricture are common. So you can see from the picture here, and then patient will also presented with the discontinuous lesion, which is known as the cobblestone. So actually, the cobblestone is like a longitudinal and circumferential fissure at the ulcer. They separate the island of mucosa, so giving it like an appearance of a cobblestone. While for the ulcerative colitis, from the endoscopy, we'll see a continuous lesion associated with the pseudopolyps. So the pseudopolyps, as the name pseudo, is actually the remnant of abnormal or regenerating colonic mucosa surrounding by the ulceration. So because the ulcerated surface is much thinner than the normal surface, so the remaining normal mucosa patch will protrude and resemble as a polyp. That's why the name of pseudopolyps. So this is part of the episode of the severe inflammation. And the treatment is actually we'll give the anti-inflammatory medications like the salicylic. Okay. So the last cause of the lower GI bleed will be the carcinoma of rectum. So 75% of the carcinoma of rectum is occur in the lower part of the rectal ampulla, and 25% will be upper part of the rectum. So the rectal ampulla, from the video you can see there, is actually in front is contact with the surface of the prostate for male, and if it's a female, then it's actually anterior contact with the posterior vaginal wall. Posterior to the rectal ampulla is actually the front of the tips of coccyx. Okay, so the 90% of the rectal cancer can be felt with a finger during when we do a upper rectal examination. That's why upper rectal examination is very important in lower GI inflammation presented with lower GI bleeding. And the rectal carcinoma is common in middle and old age, and equally common among male and females. 90% of the carcinoma rectums are adenocarcinoma initially. Okay, so patient were presented because it's over the lower part of much lower part of the lower GI. So patient were presented with the dark red streak on the blood instead of the blood mixed with the stool. And patient will maybe having a change in bowel habit because of toward the constipation because of the obstructions. And however, if the
Next
cancer
slide.
next slide. Okay. So
Are you going to talk about the whole thing about no, right? Okay, sorry.
no.
Okay,
Yeah.
alright, good.
So that's all of myself. This is all my presentation.